everyone, and thank you for joining. Welcome to today's Catalight webinar, Flexible Modalities of Care, One Size Doesn't Fit All. I'm Chris Larson, reporter for Behavioral Health Business. I've been covering the healthcare sector since 2016, and I'm excited to be moderating our conversation today. During this webinar, we'll talk about how expanding modalities of care beyond applied behavior analysis for autism spectrum disorder and other intellectual and developmental disabilities is helping to create person-centered care that improves the overall well-being of individuals and their families. We'll discuss how data plays a role in care for autism spectrum disorder and other intellectual and developmental disabilities, and the new strategies that can help reduce costs and risk across the board. We'll save about 15 minutes at the end of today's webinar for audience Q&A. So please enter your questions into the Q&A section of your Zoom window during the webinar, and our panel will answer as many questions as possible after the discussion. I want to thank Catalight and Burnett Therapeutic Services for partnering with us for today's webinar. Catalight is a healthcare provider leading the charge on person-centered care for individuals with developmental disabilities, removing barriers and biases to create a more inclusive world that celebrates everyone's unique differences. Burnett Therapeutic Services is a leader in applied behavioral analysis and mental health services dedicated to the comprehensive service model, with multiple therapists specializing in a variety of treatment modalities to provide care for many different life, mental, and behavioral needs. Today, we are joined by Dr. Doreen Samelson, Chief Clinical Officer at Catalight, and Dr. Mitze Burnett, CEO and owner of Burnett Therapeutic Services. Dr. Samelson is a licensed clinical psychologist and author with 30 years of experience in healthcare as a practicing clinician, administrator, and thought leader. Dr. Samelson provides clinical leadership for behavioral health research, developing new options or modalities of care that address unmet needs and elevate the experience of clients and their families. She's also the parent of an adult with a developmental disability and is passionate about self-determination, inclusion, and helping people with developmental disabilities improve their quality of life and overall well-being. Dr. Burnett is a licensed marriage and family therapist, board-certified behavior analyst, and registered psychological associate. Mitze's passion for helping others began more than 20 years ago when she started working in a family center, supporting individuals and families that had experienced trauma and needed supportive services all throughout her career. Throughout her career, she was the director of a nationwide human services agency, sat on advisory boards, and founded Burnett Therapeutic Services. It's great to have both of you here. Let's go ahead and jump right into the questions. First, let's talk about the prevalence of autism, officially known as autism spectrum disorder. This has exploded in prevalence in recent years, increasing from 1 in 2,500 children in the 1980s to the current rate of 1 in 36 children nationally. Why do you think so many children are being diagnosed with autism? And Doreen, why don't you start us off?
Thanks so much, Chris. And I know Dr. Burnett and I have talked about this several times because it's a really complicated issue. I was thinking back to when I was first meeting my first autistic child, which was probably in about 1982 or so. And at that time, it was a relatively rare diagnosis, right? And now we're, as you said, 1 in 36 in the nation. We're actually 1 in 22 in California. California has the highest prevalence rate. So there's a lot of reasons for that. Some of the reasons we've kind of figured out. So there's some reasons probably we haven't completely figured out. One of the things that happened is the criteria changed and we folded in other diagnostic labels that didn't used to be associated with autism are now folded into the spectrum, which, as you point out, Chris, is now autism spectrum disorder. So that certainly added to the prevalence. We also have more awareness, and I think, unfortunately, that awareness does differ around the country, and access to assessment does differ around the country. Here in California, we're probably in better shape in terms of access to assessments, but there are places in the country where really it's very difficult for a family to even get an appointment for an assessment for their child if they're worried that their child might have a developmental disability like autism. There's other issues around this. There's obviously a lot more attention in the media for autism. People know more about autism, and there is some concern that there actually might be particularly in places like California, where the prevalence is so high, some overdiagnosing of autism. One of the things that some psychologists like myself are concerned about is that sometimes we're missing the intellectual disability that can go along with autism. And that intellectual disability co-occurring with autism actually increases the level of disability for the child. So we want to be aware of that. There was actually a study done in 2019 showing that as the diagnosis of autism went up, the diagnosis of intellectual disability has gone down. Now, that doesn't make a lot of sense scientifically, so I think there's a lot of questionings about that. So as you can tell, there's just lots of reasons for the change in prevalence of the diagnosis of autism spectrum disorder. But the main point is that we want to identify kids with developmental disabilities and get them into treatment. And I know Dr. Burnett has a lot of experience in this, and she probably wants to comment on this question as well.
Absolutely. Thank you so much, Dr. Samelson. I think that the increased awareness is amazing. And I think that we, as clinicians, we have a responsibility to make sure that we are doing differential diagnosis, and we are looking at IDD, and we are looking at intelligence measures and IQ scores when we are doing assessments to make sure that we are assessing correctly and we aren't overdiagnosing. And I think that overdiagnosing can be because we know if they have an autism diagnosis, early intervention is the best thing to get in there and start services as early as we can for the best long-term outcomes. And so when you're talking about overdiagnosing, I think that there's a little bit of oh, hurry, give the diagnosis. And so we have to be careful as clinicians to make sure that we are diagnosing accurately. So I so appreciate you bringing that up. And again, just I think awareness and access to services. And I agree, here in California, we probably have better access, and our families might even be a little more, since they're so aware, they might be able to advocate. And I think we have a lot of advocating services to support families here that maybe other states aren't so forward thinking quite yet. But I think we'll get there. And so, yeah, thank you so much for that question.
Awesome. Thanks for those insights. And we actually have our first audience question that I want to address while we're still in the scene setting part of the conversation. The question is this: how often are children misdiagnosed with autism?
Well, since I mentioned misdiagnosis, I'll bring that up. I don't actually think we really know. And I think it does depend on who's doing the assessment and where probably in the country the child lives. So I don't think we know how often. I do think that we're questioning some of the prevalence rates. And the ironic thing is that we're both overdiagnosing perhaps, but we're also underdiagnosing. So both things are true. And a lot depends on where the child lives, if they're in a rural or an urban setting, or what state they live in. Some states in the US have very low prevalence rates. And as we said, California, of course, has a very high prevalence rate. So I don't think we have the answer to that question, but I think it's an important question to look at as we get more research into the area of diagnostics in general for developmental disabilities and for autism.
Yeah, and I will just kind of piggyback that with I have been doing trainings with UCSF to administer the ADOS and give the autism diagnosis. And I know that the way that we are trained is that if we do an assessment and they don't meet criteria, because early intervention is so important, we are then to go back and perhaps reassess 6 months later. And so it's the way that we are diagnostically trained is to make sure and keep an eye on kids. Now that's here, UCSF, and that's here in California, that they're saying, hey, do these checkups every 6 months. Well, if as a clinician, if we are checking in every 6 months, if we maybe missed the diagnosis originally, we could catch them in 6 months. But I think, again, it's so important to look at other factors in the family so that we don't overdiagnose. But I agree, Doreen, that we sometimes overdiagnose and sometimes underdiagnose. So it's really important to look at all of the different factors for that kiddo and that family.
And Mitzi, we're going to actually have you kick off first with our second question of the presentation. What are some challenges with autism and IDD care today beyond just the prevalence rates?
You know, we are serving such a heterogeneous population with such unique needs. And I really believe that ABA is a good option for a portion of ASD and IDD, but it's not for everyone. And sometimes it can really lack defined outcomes. Sometimes it can lack innovation. And I would, in thinking about ABA, as a healthcare service, I was kind of pondering on this for, the last week. And I thought, ABA is wonderful, but since when in any of healthcare do we say we have one treatment and that one treatment is going to last as the gold standard for the next 50, 60, 70 years? What we do across the board in healthcare is we are called to do research, and we are called to grow, and we are called to look for the best outcomes today. And as research develops and we continue to do research, typically across healthcare, we learn new scientific methods for the same sort of diagnoses. So I think in our field for autism as a healthcare field, we really need to start looking at what else could there be. We know there's a shortage of practitioners that's leading to access issues. We also need to look at affordability for payers. And so I think we, as practitioners, as clinicians, as agency owners, we need to really look at the field as autism and IDD. Where are we going with this? Because there might be new things that are developing, and that's what we're so excited to talk about today.
And if I can just
Yeah.
jump in and add to what Mitzi said, I think one of the things that we really do need to focus on is the lifespan. So, we have young children. A lot of us are very involved with treatment of young children. We have some really good treatments. Mitzi mentioned ABA, and of course, we have some developmental treatments and other treatments. And by the way, children with intellectual disability also benefit from these treatments. It's not just kids with autism, but particularly for those kids who are more significantly disabled by their developmental disability, whether that's autism with intellectual disability or intellectual and developmental disability without autism, is that taking that lifespan view. So what is going to happen when the person is an adult? Children grow up. And then what kind of services does that adult need? Do they need a supported living environment? Do they need a group home? Is there a possibility for them to work, say, with a job coach or some other supported work in place? Is an adult day program going to be appropriate for them? And helping the families make plans. And what do we need to do about making sure that the person has as much self-determination in their life as possible? Give them as much choice over their life as possible. And when we look at our more severely disabled folks, and we think about people that have very minimal language, for example, because of their intellectual disability that is combined with autism, which is a fairly common occurrence that you have in intellectual disability with autism. Then we have to figure out what kind of supports those folks need, because they usually need very high supports throughout their life. And then we have to say, okay, people age, right? And my son is now middle-aged, right? And someday he's going to be an older person, and his dad and I won't be around. And then what is going to happen, and what kind of services might be there for him? And so we have a lot of things we need to work on that really go beyond whatever treatments we talk about when a child is young.
I gotcha. So you talked about going beyond current treatments. Historically, how have we treated autism?
Well, for autism in the more recent history, probably since 1978 or so, the idea was a diagnosis of autism went directly to what we call ABA, or applied behavior analysis. And it was one particular type of ABA, and it was the type that utilizes a paraprofessional. And actually in the original studies, the university studies, like the famous Lovaas study at UCLA, they were really using graduate students or college students who had quite a bit of training. Now, in community ABA, we talk about paraprofessionals that have some training in ABA, and they work directly with the child. And there has been sort of an assumption that that diagnosis of autism or ASD, you go directly to this type of ABA. What we think we're learning now, and I know what Mitze is doing in her company and many other companies, is that we really need to have choice, and one size never fits all. So while that sort of traditional ABA can be very effective and a good fit for some families, we don't want to just go, as Mitze said, to just the one thing and then go directly to that. And then as a person ages, actually, there are other services, as I mentioned, that they're going to need that isn't ABA, things like help with employment or help with living situations and other kinds of things that the person needs.
Yeah, and I kind of wanted to add to what you were saying. You know, as an agency owner, a practitioner, a clinician, we believe in options, and we call those options modalities. We want to give our clients and families choice. We want to tell them that more hours don't necessarily mean better care. We've had families previously that couldn't do all of the hours. And so we want to provide them with options, and we want to look at well-being as an important outcome. And we really want to look at that whole family and say what is in their best interest. And so I think when we're thinking about that one size doesn't fit all, we go back to that old saying that everyone says, when you've met one child with autism, you've met one child with autism. And to remember that there's so many different treatment options that are developing, and they're so exciting right now. And that gives a lot of independence for those families and a lot of control in their decision making. So rather than us telling them, this is the only route you can take, and if you can't do this route for whatever reason, sorry, our hands are kind of up. Now we are going to almost give them a platter of options and say, hey, if you can't do ABA, we have these other research-backed, really great options with just as good outcomes, and it supports the well-being of the family. So I think, you know, as we continue to talk about this, I'm hoping that you all find these other options super exciting. As an agency owner, it just has been really heartwarming to take part in providing these services to families that couldn't do ABA or couldn't do the big hours that before were clinically recommended. And now we're like, hey, we have these other options, and we're seeing people be able to come back into care when they didn't think they had anything else. So it's really, really amazing.
I gotcha. So since we've established one size doesn't fit all in this case, what approach do you believe ultimately is best for this population?
That's such a good question, and I think it's a question that everybody, you know, asks, and we've asked ourselves. And I think it depends on the child and the family. And if you're talking about a young child, like a 3-year-old, it's very different than if you're talking about a 15-year-old with autism and intellectual disability who is nonverbal or doesn't talk and has minimal language. Very different needs. And so we wouldn't say, you know, there's just that one thing. We really want to take an individual picture of what's going on with the family and the person and really tailor that treatment. One of the things that we are seeing good success about, and I know Burnett as a company has really had a lot of success with the parent-mediated treatments. Now, you know, parent-mediated treatments aren't for everybody, and a parent parent-mediated treatment, the parent is trained to do the direct treatment with their child, the direct intervention. And that works for some families. It works really well for some families. For other families, it doesn't work so well, and we need to do that more traditional ABA model. But it's really an individual thing. And I think Dr. Burnett would probably agree with me that we need to take an individual picture of each family and child.
Absolutely. And really respecting their choices. And, when you were talking about the teen, we know that remember back when we were teenagers, right? We wanted to have control over our lives. We wanted to make our choices. It's the same. And so I think we need to be respecting the individual and setting, if it's a teen, we're looking at letting them set their own goals and respecting them to set their own goals and looking at them in the context of their family and the well-being of that family. And so, and then when you're looking at, a younger child, I have really liked seeing the parent-mediated treatment because we're giving them all of the tools to be able to succeed with that child. And so rather than having a practitioner that is taking them for so many hours per week, we're kind of saying, hey, you can do this. We can fill up your briefcase, your toolkit with all of these skills, and you can just do it throughout life. Whatever you are doing throughout the day, you can have these skill set. So then they're not dependent on us. They're actually learning the skills. And when we go back to when Doreen, you were talking about the lifelong skills, we're setting the family up for success. We're looking at the whole well-being of that family, the siblings' well-being, and everybody in that family matters, and their well-being matters.
I gotcha. So then how does this person-centered approach to care, how does that change outcomes for patients and their families? And kind of a parallel question, what does this person-centered care actually look like?
Person-centered care is looking, like I was saying, at the well-being of the child and their entire family system. We still, of course, do traditional practitioner-mediated, but we want to empower that family. We want to empower the child. We want to give that toolkit, like I was saying, to the families. And, if you look at a child's needs and on paper, it's kind of like, oh, okay, they have these behaviors, they have these skill deficits, we're going to do A, B, and C. No way, because we haven't looked at them in the context of their situation, of their socioeconomic status, of their religious choices, of their cultural, their whole family system will affect what treatment goals that we are setting for that child. So we should not have treatment goals and treatment plans that are the same. And with that, we should not have one modality that is the same for every family. And we've just seen, like I said, we've seen so many success stories now that we have parent mediated. We actually had families that, because of such a high number of hours, like I was saying, they would have to walk away from care, or we would see families kind of getting divided where half of the family is taking off to go do their normal activities, and then mom or dad is staying home because, oh, we have a practitioner coming to the home or a paraprofessional coming to the home, and so someone needs to stay home for this. So now we have that kiddo and that parent missing out on the family's activities because they're staying home for that. When if we could just empower that family and that parent and give them the skill set, they could all go as a family, and then they would have the tools and they would have the skills. And if they all want to go to a game because the sibling is playing, they can all stay together. And how amazing is that? We're not seeing families pulled apart because we are demanding high hours, which is not necessary anymore.
Yeah, those are such good points. And I just want to add, operationally, one of the things we do, of course, first is to take that deep look, as Mitze says, at the family and what the needs are, and give caregivers, parents options. And by the way, if we have a youth who does not have an intellectual disability but has autism, we want to give that youth the autism or the options, because of course youth want that self-determination. It's so important for their well-being. The other thing that I think I would add is that if we look at well-being or quality of life as the global outcome measure, that everything leads to the person's well-being and the family's well-being, that all the goals lead there. And I often say, if it's not going to improve well-being, you shouldn't be doing it. So that's where that person-centered comes in, right? Which things are going to really increase that person's well-being. So one of the examples I often give about my son cannot count money. He has minimal language skills. He doesn't count money, but he likes to buy his own coffee, and you can buy coffee anywhere if you have a $20 bill in your wallet, right? And so he has a $20 bill and he can buy his own coffee, and that's very important to his well-being. So we didn't, have to worry about, oh, we need a goal year after year after year about counting money, because my son really is never going to be able to count money. But that doesn't mean we can't get to the goal that was important to him, which is to buy his own coffee. So that's how we need to look at, that's really person-centered care, and that's care that leads to better well-being, both for the person and for the family.
I gotcha. So let's get a little bit more specific. How has the rapid adoption of telehealth changed your approach?
Telehealth is such a great option, and it's effective in many instances. I always say that telehealth is kind of the silver lining of the pandemic, if there could be one. It really pushed our field to start moving forward in, okay, what can we do to still get these family services in such a time that we maybe couldn't go to the home for a while. And so one of the modalities is where we train the parents to deliver care for their child, and we can do that utilizing telehealth now. And we're calling this parent-mediated treatment that we keep mentioning. The outcomes data is very positive, and an additional really positive outcome is that the parents are having more confidence in their abilities to support the child. And we're actually seeing less cancellations, because before it was quite a production for a family. Like if two parents are working, they have the children at school, they're trying to do drop-offs and pickups, and then we're saying, hey, when are we going to do the parent training? And they were trying to figure out, okay, when am I going to get home to do that? Now they can literally find a quiet place at work. They can go out to their car on their lunch break, and we can do this. We can do these treatments for them via telehealth. And so it's really exciting to be able to provide these skills and these tools to parents that we've been talking about. And now we can do it with telehealth. That's, like I said, the silver lining of the pandemic is now we are able to help everybody, even if they can't get home for the session.
Yeah, that's such a good point, Mitze. And I think, again, it's all about choice. For some families, they really want that in person. Other families really prefer a hybrid approach where they're doing some telehealth and some in person. And then many families, particularly those families that are really working in more of a parent-mediated model, really say, telehealth works across the board. Telehealth also works for our social skills group, for some of our youth who, they really like the idea of being on an online group, and they prefer that. Also, before we were doing telehealth social skills group for youth, it was often a struggle, as Mitze talked about, where the parent had to race home from work, get their teenager in the car, drive to the clinic, get there on time for the group, and then, no time for dinner or anything, and everybody's racing around. How modern life is for families. And so it's actually, for some families, a much better fit to have those telehealth support groups for the social skills. The other thing is, we're finding for the youth who have the language to do more of a coaching program where they're really working on their own goals to improve some of their skills, their social skills, or what we call their executive functioning skills, self-management, all kinds of different skills that are going to be really life skills for them, that telehealth really works great. They can work with their clinician coach directly through telehealth. And again, no parent has to race home from work to grab their teenager and get them in the car and get them to a clinic, or race home to be there when the clinician comes to the home, because of course parents always have to be there when we send clinicians and paraprofessionals into the home. So it just can be a good fit. But again, it's about choice. Some families, it's really not working for them. They really want more in person. And then, of course, we want to meet the family's needs and give them the in-person treatment if that's what is the best fit for them.
Yeah, thank you so much for talking about that. You know, when you were saying race home and trying to get to the appointments, and it kind of like it hit a little bit of a nerve because I'm thinking of myself and all of us that are racing from appointment to appointment. We're trying to get there on time. And if you have kiddos, you know what that's like. Like the more amped you're getting as a parent, like we got to go, we're going to be late. We got to, and then the kids are getting amped up. And so when we're looking at the well-being of a family and really trying to lower that stress index for that family, it's so much easier if they're like, you know, I can just jump on here. And whether it's a teenager like getting on there, or whether it's the parents doing parent mediated. And so it just, when you said that, it kind of hit a nerve. Like, I know what that's like. Like, it's so stressful when you're late and you're running here and there and everything, you know how it goes as a parent. And so we're really wanting to lower that kind of that stressful situation for them and to give them the tools that they need. The other thing I wanted to bring up is the shortage that we have of practitioners in our field. Because, you know, when we're talking about sending our BCBAs or our practitioners out into the field, they a lot of times are sitting on the freeway, or they're on country roads that are taking maybe a couple hours to get to a session. And then, as you know, as an agency owner, I'm looking at those staff going, that's really quite a burnout, because they got into this field because they wanted to help. They wanted to be with the kiddos. They wanted to be with the families. They wanted to provide the services. And so in terms of not only the shortage we have, but really trying to give the BCBAs what it takes to fill their cup. And we know they want to be with the families. They don't want to be stuck on the freeway. And now we have a shortage of BCBAs and we have them parked on the freeway. And so it's really not always the best use of time. So I love the hybrid model for that reason, because maybe we have a paraprofessional in the home that is providing those services, but the other staff and the BCBA, they can just provide telehealth, and they can actually be almost in, like, sometimes in an earpiece of the paraprofessional, and they're in real time in that session, but they didn't have to sit on the freeway and waste their time. And so in terms of trying to help with staffing burnout and staffing shortage across the field, it's really helped a lot with that.
I gotcha. So we've already talked about how telehealth can improve access, but are there any other ways we can highlight or identify how telehealth and other innovative approaches to care can improve access and get families off of wait lists? Access is a big challenge in the behavioral health industry, as we all know. Doreen, how about you start us off there?
Yeah, so I think obviously telehealth can be helpful. I do want to say one caveat about telehealth. If we're talking about young children and we're talking about traditional ABA, where we have a paraprofessional doing the direct ABA, we don't want to do that by telehealth, because we don't want young children to have a lot of screen time. There's actually research about brain development and screen time. So I just want to be clear, no one is sitting a 3-year-old in front of a screen and having a paraprofessional on the other side do ABA. That actually does not work very well, and is not a healthy option. I think that the parent mediated certainly does help in terms of access, because we don't need the paraprofessional, that RBT. There's a couple of other certifications that paraprofessionals can get, but RBT is probably the most common one. And agencies find it very difficult to keep paraprofessionals. They're usually high school graduates. They're young. The job market is quite good out there right now. So they might, work as a paraprofessional for a while and then find that they can get a job at Starbucks or something, where you get free coffee, and we don't get free coffee in ABA, I guess. So, they may leave, and that happens a lot. And so the research says across the country, and I go to a lot of conferences and talk to a lot of people across the country and even internationally, it's very hard to keep those paraprofessionals. So certainly having some components of parent mediated for the families, for what that's a good fit, that can improve access. The other thing we want to do is to really mentor and help young people come into the field. We need a multidisciplinary approach to our kids and our families, because often the needs are very complex, and the needs of kids with autism spectrum disorder and the co-occurring conditions like intellectual disability make things quite complex. So we need that multidisciplinary team. So we need more BCBAs. We want to encourage young people, particularly young people from underrepresented groups. We do not have enough practitioners. We don't have enough Black BCBAs and Latino or Latina BCBAs, for example, or bilingual BCBAs. We don't have enough psychologists who are really trained to work with the population of developmental disabilities and autism. So we want to encourage young people. If there's anybody out there who's starting in college and isn't sure what they want to do, this is a great field to be in, and we want to be able to, really support people in coming into the field. And then I think we want to really educate the whole community. The more the community is educated about developmental disabilities, the better it is for everybody. And so, we've got a lot of work to do, but we're very dedicated with making sure that access happens. We don't have wait times at Catalight, a very short period of time for people to get into treatment, which is so important. But we're aware that around the country and in other countries, there is often times that people have to wait. And as Mitze mentioned, the earlier you can get a child into treatment, the better. So we really don't want kids, especially young children, to wait.
I agree. It just really, when you're talking about the young folks that are coming in to be paraprofessionals and what have you, and again, as an agency owner, I'm we're always looking at what career path can we provide to them, because you're right, it's hard to recruit them. It's costly to train them, to get them onto a client and be working with a family. It's a lot of work. And so in terms of looking at the training and the mentoring and everything that we provide to them, when they decide to go to Starbucks for that free coffee, then it's like, oh my goodness, all of the people that just poured their hearts into mentoring them, and then with the turnover and they decide to leave, not only are they leaving that kiddo and that family, they're leaving all of the staff that just poured all of their time into training them. And that kind of, could lead to burnout for the BCBAs that are training them and trying to mentor them up. And so I think we should start offering free coffee. No. Maybe that could be a recruitment tactic. No, I'm just kidding. But yeah, I think it's important to make sure that we are offering the young people a career path and really showing them that in this field, you get to make a difference. You get to change people's lives, and you get to give back, and it just feels good to do that. And so I think if we could develop our young people and, like you said, get more Black BCBAs and Latino BCBAs and of different cultural backgrounds and ethnicities, I think that would be amazing. So we're always brainstorming on how to recruit people into our field and how to help the families that have a child with autism or IDD, or even an adult with autism or IDD. So thank you for that, Doreen. I appreciate it.
Awesome. And I want to remind attendees that you can send questions through the Q&A function here on Zoom. We got 2 more questions that we'll be going through and then getting to audience Q&A. And first of those last 2 questions, for providers and payers in the audience, what important messages would you like to leave with them? And Doreen, why don't you go and kick us off?
Well, for providers and payers, here's what I would say, and I'm repeating myself a little bit about well-being. Everything we do for people with autism and intellectual and developmental disabilities needs to be focused on improving well-being. And if we do that, we'll be doing the right stuff. If we fall away from that and we start to think, oh, well, this has to be this way or it has to be that way, then we're probably going to go in the wrong direction. And I think that we do need to listen to many of the autistic adults who say, look, you know, I'm fine with who I am. You don't need to change me. And that goes to well-being too. So we want to help people change when they want to change. We want to help young children gain the language skills, the communication skills as much as possible so that they can have more self-determination in their life, but it really needs to be rolled up to that well-being. And if we think about well-being as our global outcome measure and everything else that we measure for outcomes goes in that direction, and we often offer families choice, I think then we're going to be improving the lives of people with developmental disabilities and autism.
Yes, absolutely. And I appreciate you asking this question. You know, I think my hope is that people will walk away from this and be open to thinking outside of the box, put their forward-thinking hats on and realize that there's other options that have been rolled out, or maybe they haven't yet, but there's research being done on what is out there on parent-mediated. There's so much research now showing that this is supporting better outcomes for some families. Again, traditional ABA might be for some families, but I just want to challenge everybody to be open to change and to be open to getting out of your routine and what's comfortable to you. I think all of us got super, super comfy in ABA. Traditional ABA is the golden standard, but just to really open up your minds, open up your hearts to understanding that if we are focused on well-being, it doesn't matter what modality it is, if it's the right one for that family, and just to be open to that. I think that that's what I would like to leave with everybody.
Gotcha. If you could look down the road 10 years for ASD and IDD care, what would you imagine as being different?
Well, I think one of the things we need to be very careful about is to make sure that we are aware of the intellectual disability. We have too many kids who are being diagnosed young with autism or autism spectrum disorder, and then they're not getting follow-up assessments around the possibility that they might have an intellectual disability. And the reason that that is so important is that that group that has both autism and an intellectual disability is the group that needs the most supports going into adulthood often, and different supports going into adulthood than maybe somebody with autism without an intellectual disability. We also really need to be paying attention to another group that we haven't mentioned, and that is those children with autism and ADHD. That's another group that's a specific population within the spectrum, and they have different needs. So I think what I'm saying is we really need to be very careful that we understand the full needs of every individual as well as the family, and make sure that we're addressing the particular needs for the subpopulations that exist within this spectrum. This spectrum is extremely wide. The needs are extremely different from different subpopulations within the spectrum. So I'm hoping that we will be, really being a little more sophisticated in the way that we look at autism and developmental disabilities, and make sure that we're meeting the specific needs of all the different populations within the spectrum.
Yes, I think the way of the future, or maybe I should say my dream of the way of the future, is that agencies really do start focusing on the needs of the family, and that businesses figure out maybe even a new business structure. I know that the old way has always been the high number of hours, and that businesses are set up that way. Because when I started my ABA agency, that's how I was set up. But when I started learning about some of the other modalities and parent mediated, I thought, well, why did I get into this? I want to do the best thing for the families. So how do I change my business strategy to offer these modalities? And how do I make this work? And so my dream for the future is that everybody can kind of learn these new ways and these new modalities and be open to change. And it's not always easy. We all get comfy with things, but push yourself to be better for the families and remember why we got into this. You know, we all got into this because we loved this population and we loved helping the families. And so my dream for the way of the future is that business owners and agency owners figure out that, hey, we have a shortage of staff. We have a duty to this field to figure out how to work together to provide all of the services that are necessary. And with the rates of autism rising, we can't continue the way that we have, and it's not necessary. When lower hours, we are showing with research that they're just as effective. So my hope is that people will get on board and realize, you know, if we push ourselves out of our comfort zone and it's the best thing for the families, then why not?
All righty, we're going to transition to the Q&A portion of our presentation. And Doreen, you mentioned a couple times making sure that we are assessing and considering well-being. There's a specific question here. How do you measure well-being in this context?
Oh, that's such a good question. You know, that we asked ourselves this question at Catalight and the Catalight Research Institute, which I'm just so such a pleasure of mine to be involved with the Research Institute. And we actually looked at what kind of scales were out there or measurement tools, and we couldn't really find anything that was really going to work for us. There's some really good ones that are kind of interviews, but you can't do long interviews with families every 6 months. That doesn't work, so it's hard to track it that way. So we've actually developed 3 well-being scales: a family, a youth, and an adult well-being scale. We've published, we're presented at conferences. We've got publication coming on both the family well-being scale and the youth well-being scale. I think Burnett was one of the companies that helped us pilot and get some of the data for those scales. And we have very good psychometrics for those scales. So by using those scales and tracking over time through the treatment, the well-being of the family or the youth or the adult, we can really make sure that what we're doing is on track. And if what we're doing is not increasing well-being, as I said before, then we have to think about doing something different. So that, I think, is a really good way. These are measurements. These scales are taking the feedback from the person, right? Their self-report. So they're telling us about our well-being and their well-being. And I think that's the really important thing that we're doing around well-being, is measuring it. Thanks for that question. Great question.
Gotcha. And just so we can try to get to as many questions as we can, I want to keep with a similar one. What is the best screening tool for non-mental health outpatient providers? So, for example, people in the family medicine, urgent care, and other similar settings.
That's a really good question, too. And if you don't mind, Mitze, I'll start. And if you have anything to add, you can certainly jump on that. There are a lot of autism screeners that pediatricians and other people use. The problem with autism screeners is when you're looking for one thing, you usually find that one thing, but you might not find other things that might be going on. So we're in the process now of actually working on a screener that screens for developmental disabilities. And there's really not a lot of good screeners out there for like a pediatrician to use or a family medicine doc to use that really look at more than just autism. So right now, I think we're in a place where we really need to think about how we can get a tool out there that can be used by primary care practitioners. At this time, I think most pediatricians or other primary care practitioners are using something called the MChat, which looks for autism, and it certainly does screen for autism, but as I said, it misses other developmental disabilities, but that's probably the one that is more most likely used. But hold on, because in a year or two, I hope that we'll be able to share our screener that Dr. Nina Rudnick and Dr. Lindsay Sneed are working on here at Catalight. And so more to come on that screener.
That's super exciting to hear. I didn't know that, but you know, in the urgent care clinics and the doctor's offices surrounding us in our community, the MChat, I know you mentioned that. I don't think that they have good screeners. And a lot of times what they do is they'll call like me, or they'll call one of my directors and they'll say, hey, this is what's going on with this kiddo. What are your thoughts? And we always say, if you have hesitation or you think that there could be something, our recommendation is to refer them to a psychologist, get the psych eval going, where there can be a more comprehensive study done on that child or evaluation, and then they can be referred back to services. But exciting that you've got that in your back pocket coming up, because it is a need, and I see it because they're calling us, asking us like, hey, we're seeing this, and there should be a better standardized screener. I love that.
Awesome. And Mitze, this might be a good question for you to start off on. So insurance covers ABA therapy, but not other treatment models. How do families afford participation in a non-reimbursable parent-mediated treatment option?
Well, first of all, parent-mediated, from terms of a financial perspective, would be a lot more affordable than if we were going to provide a 3-tier or high hours, because I can understand that gets very expensive. But if we're thinking about providing parent-mediated, and it depends on the child's needs, it would be a lot more affordable for them. One other thing that we do, depending on their insurance, and potentially they might have, if they have an autism diagnosis, a lot of times they can work with their regional center to get Medi-Cal, or in our area, partnership as the backup insurance that will cover. And we work with the family to figure out how to get insurance to cover the services, whether it's their primary or their secondary. It has always been a passion of mine. And thankfully, in my community, the doctors' offices are on board, and the psychologists and everything. So we're all collaborating and we're discussing, how can we get these services covered? And now there's other diagnoses that are eligible. You know, we open it up to a lot of diagnoses. We serve ADHD, OCD, and different things. If the symptoms are interfering with the child's development and it is documented by their physician, we actually can use other diagnosis codes to get insurance to pay for it. So I think agency owners need to be creative and collaborate with others and figure out how to get these kiddos services. And again, if it does have to come out of pocket, parent mediated is so much more affordable.
If I can just add, in California, really it's behavioral health treatment that is covered for people with autism and other developmental disabilities. So it's not just ABA. So insurance does cover, and it's a little different state to state in terms of the law, but all 50 states certainly cover autism, and most states talk about behavioral health treatment, not necessarily just ABA. So I think, as Mitze said, working with their insurance company, working through the regional center if they're here in California or whatever state that the person lives in, is important. But really, I think that we again need to look at behavioral health treatment and not just ABA, and mostly that is covered, at least in California.
I got you. We got a kind of a different question here. Can you please speak to late diagnosed adults seeking resources and services for themselves?
Yeah, that's a real need. I think there's more awareness for adults. Again, mostly these are adults who do not have co-occurring intellectual disabilities. These are people with language who may have struggled with different parts of the autism spectrum during their life, particularly social skills or executive functioning skills or other things. A lot of these adults might also have co-occurring ADHD, which makes things more complicated. I think there's not as many services for adults in this population, but there are some really strong advocacy groups. So autistic advocacy groups where autistic people are actually helping each other and supporting each other. And there is, if somebody has a diagnosis, the opportunity to get some services. Those services could be from voc rehabilitation, for example, in terms of occupational services. There's not enough out there, but there are self-help groups, really autistic advocacy groups that help and share information with each other and support each other. And there's just a lot more information out there than there ever was before. So I think it takes a little bit of work on the autistic adults part, but they can at least find some other people that may be able to help them with ideas about what to do to improve their well-being and what the goals that they have for their life. One of the things we don't want to do is say, you know, you don't want to be autistic and you can't be autistic and you're going to try to not be autistic. That is not the right way to approach it, right? Adults, autistic adults who have good language, they can make decisions on their own about, you know, what parts of their autism they want to embrace and what skills they might want to learn to make their well-being better. But it needs to be their decision.
Yeah, and I just real quick, I wanted to say that for adults here in California, you know, if they weren't diagnosed before the age of 18, a lot of people feel that the regional center is not a resource, but the regional center also had, here in California, the regional centers actually have a lot of information on like what Doreen was talking about and different support groups. And, you know, if they can find a safe Facebook group and with maybe a little bit of monitoring to make sure that it's a safe group, there's some really awesome support places that they can network with a little bit of help.
Now, how would you recommend approaching a family to suggest getting an ASD screening for their child?
Well, the first step is to really go to probably to the primary care provider, the physician or the family medicine doc, if they have a family medicine doc instead of a pediatrician, and to say, you know, these are the things I'm concerned about. This is what I'm seeing, and ask for a full evaluation. And I think most pediatricians and family medicine doctors are very aware that we need to catch kids early and that early intervention works. They can also go to the regional center here in California. Each state is different. So there's, you know, different systems in different states. So they have to look to see what their state system is. But most primary care doctors at this point, I think, understand they may not be able to, they're not going to diagnose autism. They may not understand fully all the needs of an autistic child, but they know some of the basic signs of autism, and they know that we need to get into early intervention. We also want to make sure that we're ruling out other things. For instance, is the child having problems with hearing? Are they hearing impaired or are they deaf? You know, is there something else going on? We want to rule out some of those things, right? And so that the first step would be going to your primary care doctor or provider.
Yeah, and I just wanted to also say, don't be afraid to push and advocate, because sometimes when you talk to your doctor about your child and you're like, hey, these symptoms are going on, sometimes, you know, they're late and they're rushing through and they're like, okay, we'll keep an eye on that. Don't be afraid to push and say, no, I really want you to refer us to have a psychological evaluation done on my child. I have concerns that we might be seeing something more along the lines of autism. And I just want to make sure, as long as all of those other medical things could be ruled out that Doreen was mentioning, but really push and say, I need a referral for that. And don't be afraid to ask, because sometimes doctors get busy too. It's nothing personal. They just have, you know, 25 patients to see in a day or whatever. So push and ask.
Yeah, Joe, winding down. So let's have a couple of brief thoughts here on this last question that we're going to ask before we wrap up. So how can new approaches help reduce costs and risk for the ASD and IDD population?
Well, in terms of cost, I think when we talk about the parent-mediated approaches, they generally are less costly because you're not paying a paraprofessional. In terms of risk, you always want to have that high-level clinician involved and making sure that we're really tracking outcomes and we're really making sure that we are making progress. If we're not making progress, then we need to do something different. If we have dangerous behaviors, we don't want to wait too long. If we're not seeing improvement in dangerous behaviors in a couple of months, we really need to get in there and look and see what's happening. And maybe what we're doing isn't working and we have to do something different. So I think those would be the two things that I would think about. And there's probably more, but I know we're running out of time. So.
And I think we'll end there because I love what she said and we're out of time.
Awesome. And there'll be chances to have other discussions like this in the future. I just want to thank everyone for joining us today on our webinar titled Flexible Modalities of Care, One Size Doesn't Fit All. I also want to express my thanks to Dr. Samelson from Catalight and Dr. Burnett from Burnett Therapeutic Services for partnering with us on such important topics surrounding autism spectrum disorder and other intellectual and developmental disabilities. Please keep an eye out for an invite to the next webinar in our series with Catalight. Thank you again for joining. I'm Chris Larson, and we'll see you next time.
Thank you, Chris. Goodbye.
Thank you so
Dr.
much.
Burnett.